Thank you so much. Well, welcome everybody. What I'm going to do is I'm going to get started. So welcome everybody to this. Can everybody see my slide okay there? Super duper. So welcome everybody. As I said, my name is Zoe Hughes. I'm the Senior Policy and Research Officer with Care Alliance Ireland, but I'm also wearing a kind of a secondary hat today because traditionally as part of our AGM, we usually make a presentation on a topic that's come up during the year or something that we've been working on or one of our projects in Care Alliance. And this year it's my turn again. And so what I'm going to do is present my doctoral work, which is in the area of queer family caring. And so I've been working on this for a number of years now. COVID kind of put a bit of an interesting timeline on things. And I had some various personal issues as well that have kind of, I think if anybody here has done a PhD or any level of studying, life happens. And if there's any family carers on the call, life definitely happens in the middle of all the best laid plans. And so I'm continuing on. And so what I'm going to do today is I'm kind of speaking from that doctoral student hat. So just to be clear as well, this is work that I'm doing outside of my work with Care Alliance, but Care Alliance have been very supportive throughout my time doing this doctoral work, which is really, really appreciated. And again, just for anybody who's come onto the call late, just to let you know, we are recording this. So I'll be chopping this down and going ahead and putting it up on our YouTube channel for people to watch afterwards. So that's what we're going to talk about today. And so moving on. There we go. Before I start, I want to just do a quick note on language, because when you're talking about family caring, but also the LGBT community, of which I am a member, people can kind of get a bit scared by some of the language that's used and kind of go, is it okay to say that? Are we all right to use that language? And people have very strong opinions on the language that we use, and that's absolutely fair. But I just wanted to set out my stall as to where kind of I'm coming from with this, as someone who's been working in the family care space for a decade now. I've been a family carer myself many years ago for my mother. I'm currently going through it with my mother-in-law. I've also, I'll be a carer again in the future, no doubt. So I just wanted to be a quick note on language before we start. So I use the kind of, within this presentation and within my work, I use the word queer, LGBTQ+, and sexual and gender minorities / SGM as kind of interchangeable terms. To kind of, the reason I want to do that is because there's no really one phrase or one word within the community that everybody's super happy with. There's as many different opinions on language as there are people within the community, and that's really good. That's a really good thing. That lends a lot of richness to the debates that we have and the identities that we build in the communities that we're part of. But I just wanted to say that I'm using them interchangeably because some people really don't like the use to use the word queer, for example. That's okay, but I use it for myself. Likewise with LGBTQ+, there's many different iterations of that. They all have historical significance. And then sexual and gender minorities is kind of the academic one that's used most broadly currently. So they're all in there as well in the kind of the usage of terms that I have. And so, as well as that, queer can encompass more than a simple statement of sexuality or sexual attraction. So queer can also include a cultural element, there are a lot of people who, for example, would see themselves as culturally queer as well as being part of the LGBT community. And some people absolutely do not. And even within my research and some of the topics I'll talk about throughout this next presentation, there's elements of that where people were really not happy with me using the word queer as part of my research. So we can talk about that a little bit. And then, so when I'm talking about a queer family carer or an LGBTQ+ family carer, what I mean by that is a family carer who identifies as part of the LGBT+ community or who views their sexuality as non-heterosexual. So that's why I want to encompass as many people as I can in this. So basically, if you identify or you see yourself in any way as non-heterosexual and are a family carer, providing care to either a family of origin, family of choice, friends, neighbors, your own children, your parents-in-law, grandparents, spouse, whoever it might be, that's all part of this research. It's all encompassed within this research. So when it came to looking at this topic, I was inspired kind of by some of the work that I did early on in my work here with Care Alliance, where I set up the discussion paper series. And it's kind of, I like awkward questions, I like thinking about the things that happen at the margins of society. So there's lots of work and we know quite a lot in lots of ways about the experiences of family care is kind of in the middle. So in that bell curve of kind of who's a family carer age-wise, you kind of, there's young family carers and it peaks at sort of women in their 40s and 50s, and it goes down again a little bit as people age. So there's a big kind of bell curve, and lots of the work that's done encompasses that big big bell curve in the middle. But I'm always interested in what happens at the margins, and whether that's through margins of age, location, whether you're a rural caregiver or urban, whether you're part of a minority group, whether that's a religious minority, a sexual minority, an ethnic minority, whatever it is, because it's only natural that a lot of the work that we do, and you know, particularly in the NGO sector, we kind of need to get bang for buck essentially with what we're doing. So that goes for research as well. It's kind of like, well, you know, I want to do research that's going to affect change for as many people as we can, as well as we can, as effective as we can, with, I suppose, the least amount of money we can, so that there's more money to go around, because, you know, money and funding from the government is not it's not an infinite resource as much as we might like it to be. And so that's kind of where this came from. So I decided to have a look at what had been done previously, specifically around LGBTQ family caring. And it's quite a small body of research in comparison to a lot of other topics and even other minority groups that are within the caregiver space. And it's primarily, all that work has primarily been done in the US, Australia, and the UK. So to date, I haven't found any research that's been done, other than some of the stuff that I've been doing, around the LGBTQ family caring in Ireland. If anybody knows of any that I'm not aware of, please do let me know. I know currently there are more and more we're getting asking questions, say, for example, in large scale surveys, people are being asked a question around what is your sexuality, and we can look at that data through the lens of sexuality, as well as through, for example, ethnicity, age, rural, urban divide. And that's really, really helpful. But for a specific dedicated research around the challenges and opportunities around family caring in the LGBT community, there isn't any, essentially, in Ireland, in an Irish context. And where there have been studies done, a lot of it is kind of, it's around the negative stuff a lot of the time. You know, you're looking at focus on, for example, AIDS caregiving. So a lot of the research in this area started in the 80s and 90s, looking at family caring from the family of choice perspective. So not necessarily your family of origin or your blood family, but around caring for a person, predominantly gay men, who had contracted AIDS or HIV within the epidemic in the 80s and 90s, where really it was left to a lot of the community groups within the LGBT community to kind of step up and provide that care, because it wasn't necessarily provided by the state, certainly not in the US and the UK. It's a slightly different experience in an Irish context, but we don't have time to get into a big long spiel about the AIDS crisis in this particular context. You have work being done around the aging within the LGBTQ community broadly. So what's it like to age as a queer person? Very often, you know, sort of from the 70s, 80s, and 90s, people didn't really live that long. You know, we're now only getting now to the point where there are openly gay people who are living to 60, 70, 80 and onwards. What does that mean for aging? What does that mean for provision of services? So that's another kind of a little sub area within the broader field. Looking at LGBTQ plus care recipients rather than the carers themselves. So the focus on the recipients of care, so queer people as recipients of care. The impacts of heteronormativity, homophobia, and heterosexism. Now, I appreciate not everyone on the call will, these are my bread and butter terms, so I appreciate not everybody is going to know what that means. So I think most people know what homophobia is, or at least have a good idea of it. It's kind of like, it's the only ism, I guess, that isn't called an ism. So you've got racism, sexism, ageism, ableism, you know, all in that kind of same area, I guess. And then we've got homophobia, which doesn't really mean you're scared of gay people. You're not like, it's a gay person. It's not like that. It's more so that kind of, you know, it's the ism around gay people, if that makes sense. And then so heterosexism is really the idea that heterosexism is often a kind of a more of a structural idea, where really that heterosexuality is the norm and should be the norm. And so that's a kind of a viewpoint of individuals, but then also previously, certainly in the 80s and 90s, 70s and 60s, would have been a general policy viewpoint of governments and of society at large, that, you know, heterosexism is the right way and homosexuality is the wrong way. And so that society should be structured around heterosexuality as the right way and the right norm. And then heteronormativity is slightly different, but it's basically kind of a lot more kind of like, again, heteronormativity is the norm, and that's how society. They're very similar, but they are slightly different. But again, I don't want to get into the weeds of the words because they're not super related to the topic at hand today. Distrust of agents of the state, and so what I mean by that is many family carers just don't trust agents of the state, and by that I mean security, so the police, the Gardaí, the agents of the state, also including health and social care professionals, basically anybody who's paid and is working for the state. There's often a distrust there because of previous experiences when homosexuality was criminalized in Ireland, for example. So you'll get a lot of older gay people saying, I don't want to go into my doctor because I actually don't trust them, because when I went into them when I was in my 20s, I was told I was wrong and that I could have been, I was arrested by the cops when I was 25 because I was queer. So there's a distrust there, and that builds up over time. And obviously, if you're talking about aging and family care, that can have a real impact, because if people aren't willing to put their trust in those agencies of the state, and particularly in health and social care, that can have a really negative impact on their health moving forward and how they're actually aging well in place and accessing the services that they need. And where there is a focus on carers themselves, they're normally focused on gay carers and lesbian carers, and sort of never the twain shall meet. And there's certainly nothing really in there around bisexuality or non-monosexuality. And so that's kind of a very whistle-stop tour of the literature that's been done to date and the research that's been done to date in this area. So then I kind of decided, right, well, I need research questions, because every good research needs research questions. And so these are the research questions. I'm going to take a drink because I've been yapping for 10 minutes solid. So I'm just going to take a quick drink while people maybe have a read of those. Oh, that's nice. So what are the key demographics of Irish family carers? So really, I wanted to just look at, like, we don't know anything about Irish family carers who are queer. So we need to at least get some idea of who they are, where they are, what age they are, where are they living, where have they come from, what are they doing, essentially. And then I wanted to look at identity and how people's experiences, both of their sexual or gender identity, impacting on their experience as a family carer, and then flip that and say, well, what does being a family carer in this instance, how does that impact upon your identity and your experience of being part of the LGBT community? And then I wanted to identify what challenges there are and opportunities there are that are unique to sexual and or gender minority family carers, and what are their identified unique support needs. So there's an awful lot of use of the word unique in there, impact, all that kind of stuff. So that's what I've been working on for the past couple of years. But spoiler alert, again, for anybody who's done or is doing a doctorate, the research questions, sometimes you have supervision and your supervisors say, hey, let's have a think about these. So right now, these research questions are, they're under maintenance. Let's just leave it that way. It's going to stay roughly the same, but I am having to look a little bit more at how I'm moving forward, because this is what my research looks like right now. So, and it's very exciting because for a very long time, I was stuck in this area here, right? And now I'm all the way over here, which is very exciting along the timeline. So that's great. So to date, I've kind of done a literature review, which it looks there like your literature review, and then you do your research questions. Your literature review covers all of this, which is disheartening, but also really great. You got your research questions. I've done a survey, and so I'm going to talk a little bit more about the results of that survey and what both academically I'm taking from it and moving forward, but then also what you guys as health and social care professionals, policy workers, whoever it might be that's come along to this talk can actually take from what I've discovered so far. And then looking at the identification of nodes. So looking at, if I could, so I've gone wide. I've kind of got, okay, I've asked loads of questions, and I'll talk about that in a second. And this is what's coming up again and again and again and again in an Irish context, which is different or the same as internationally. So let's dig down into that one more, or let's dig down into this one more. So that's kind of where I'm at now. So the survey. I did an online mixed method survey. So I asked qualitative and quantitative questions in that. The questions were based on the literature review. So what I did was I kind of looked at a lot of the research, all the research that was coming out that I had found in the US, the UK, Australia, Canada, some in European countries, although relatively little, and some from South America. And there was a couple of studies in South America and Brazil in particular. So trying to find, I don't speak Spanish, unfortunately, so trying to find those, I needed to find translations of those. We got there in the end. And I developed the questions for the survey from that. So these are the key topics that came out of other people's research. Is it the same in Ireland? I don't know. So let's find out. And that's how I came up with my survey. Also, some of the wording and some of the questions that I used, particularly for demographics and looking at mental health outcomes, was taken from the Burning Issues surveys, which were a series of surveys within the LGBT community based in Ireland. And the reason I did that was I wanted to make sure that if I could do some comparative work between family carers in the LGBT community and non-family carers or general population within the LGBT community. So that's why I did that. And I had 49 responses, which doesn't seem like an awful lot, but when you're looking at a niche of a niche of a niche, it's not too bad. At least that's what I say to myself. And my supervisors agree, so I'm going to take that as good, you know. So we have 49 responses. So I'm going to talk a little bit more now about the responses and what's coming out of it. So a little bit about demographics. So just so kind of people are aware that this is who responded to me. The majority, which was 39%, identified as lesbian. So within that, obviously, there was another 60% that were made up of gay, of pansexual, bisexual, and other forms of identities. Majority were 59. 59% female, which is the majority. We had some I think it was 20, I want to say 20 or 25% non-binary, and then the rest were binary male. Just under a quarter identified as non-monosexual. So by that, I mean bisexual or pansexual. And if there's, by the way, if there's any terms that I'm using or any, you know, if anybody has any questions, please pop them in the chat because I can see them and I can address them. Because I realize that when you've been in this for so long, you can kind of just use words and use terminology and expect people to know it. And I really don't want to fall into that trap. So I try and explain them as best I can. But do please ask in the chat if you have any questions. Just over half were aged between 36 and 55, and that really kind of checks out on that age bell curve of family carers in general. You know, that's where it peaks at that same age group, so nothing much different there. The majority, nearly 3/4, were living in an urban centre. So that's either a small town, a large town, or a city. So just what, a little over a quarter were in a very rural area. And over half, just over half, were caring for a parent, step parent, or parent-in-law. So caring kind of up that level. So thematically then, so I kind of got all of this, and there's a lot of information. I have so many Excel spreadsheets. I have so much data that I'm combing through. It's very exciting. It's really exciting, and I do enjoy it, but it's a lot because you have 49 responses, and I think I want to say 45 or 46 questions. And then you have multiple you've got qualitative statements as well to work through, which is really fun and exciting. But I'm still reviewing and analyzing that data. It's going to be and keep going. But looking at some of the themes, some of the stuff that really jumped out at me, you know, I've got a big notebook of, you know, that studious notebook of, oh, this is what this is, and this is this theme, and blah, blah, blah. So if anybody wants to see my notebook, I wouldn't recommend it because I can't even read the handwriting sometimes. But that's tomorrow's Zoe's problem a lot of the time, unfortunately. But some of the themes that are coming out of the research of what I've been finding is looking at rural caregiving, but in the context of being queer. So what does that mean? So there's a chunk of people who responded to my survey who left Ireland or who left their rural kind of backgrounds. Some because there was very little life for them in Ireland back in the 80s and 90s. Just there was no LGBT community, or there was very little, so they had to leave, had to go to Dublin essentially, or Cork, maybe Galway, but it was usually Dublin or it was usually London, the two big places that came up, and that checks out for a lot of the queer community and at those times as well, leaving just to get out and to where things were legalized, because obviously we didn't, not obviously, I shouldn't say obviously, but homosexuality was decriminalized in 1993 in Ireland, whereas it was in the 60s and 70s in most of the European, not most of the European, but Western European countries. Certainly the UK was 1969, I believe. So it was a little bit more viewed as a little bit more open. So a lot of people moved away. And so now people are moving back to care for their aging parents in a rural context. So what does that mean? How is that impacting them? The coming out journey. So we usually think of coming out as when people sort of, you know, basically say, I'm gay, this is who I am, and this is the life I'm going to live, both to themselves and then subsequently to other people in their lives, and then to people in general. And so that the coming out journey as a queer person, But then also there's a side kind of narrative underneath all of that of coming out as a family carer, which I find really interesting, where people are kind of like, oh, this is another part of my identity. So what does that mean for me? Do I tell people that I'm a family carer, particularly in dating, for example? And that's something that's come up not just within the queer community. I wrote a paper, part of the discussion paper series a couple of years ago, around how family caring can impact upon your intimate relationships and your sex life, essentially. And people were saying that like, at what point do you tell people you're a family carer? At what point do you say, hey, by the way, you're actually not going to be my priority? Sorry, that's not exactly a sexy thing to say in your dating profile. So how do you manage that, and where do you go with that? Non-monosexuality and bi-erasure. So bi-erasure, for those who aren't aware, is kind of the erasure of bisexuality from both the queer community, but then also just in general society. So I'm specifically going to talk about that in a few moments. I won't get into it here. What I think will probably be the most interesting to a lot of people on this call, which I am going to talk about in more detail, is engagement with support. So looking at people's engagement with LGBTQ plus organizations and community groups as a family carer, but then their engagement with family care focused and health and social care supports as an LGBTQ person. So looking at how both kind of sides of life and both aspects can impact each other and have an impact on how those different supports are being experienced, but then also some people who just don't even want to go there with supports, either because they don't feel there's anything for them in their local area, whether that's because they're LGBTQ or just there's very little HSE supports or community-based supports or NGO support in their area, or whatever it might be. If the impacts of family care responsibilities on their involvement within the queer community. And again, not everybody who's LGBTQ plus wants to be part of a queer community at all, and that's perfectly valid. But for some people actually really, really do. And that's an integral part of who they are and part of how they live their life. And then, as any family carer who's on the call who has experienced family carers who worked in the area knows, that in general, like, this isn't unique to LGBTQ plus folks. That idea of, we have no time, I can't even go down to the local coffee shop for however much long time, I need to be at home, or whatever it might be. And so it's no different that way. But it is something that has come up a number of times within the research. Strengths and resiliencies, and looking at, again, the title of this talk today is the strengths-based approach. So I'm going to talk about that more in a little bit more detail next. And then attitudes and experiences with health and social care professionals. Spoiler, maybe. When I looked at what people were saying in my data around, trusting health and social care professionals, or experiences of homophobia, for example, from health and social care professionals, was generally much more positive than in pretty much every other piece of research that I've read from other jurisdictions. So that's a really positive thing to take from the Irish context, is there's a lot less concern about attitudes from HSE staff and healthcare staff and social care staff, and a lot more of an assumption of, well, they're professionals, so they're just going to get on with it. It's nothing to do with them, So there's kind of so that's a really positive thing to take from this, which I think we should all be in the sector. We should all be quite proud of, actually. That's something that is obviously starting to come through. Not entirely sure why, but I'll talk about that in a sec. Does anybody have any questions before I move on, or will I just keep going? Very conscious that I'm talking at speed. When you're excited about something and you kind of, this is something I'm quite passionate about currently. Was the positive experience with health and social care staff a new thing or a lifelong per participants reporting? I didn't specifically ask that, Liam, to be quite honest with you. I didn't specifically ask that. That would be something that I would like to ask perhaps in interviews. There wasn't really space there. Thank you, Elaine. So yeah, I'm not entirely certain, but I suppose what we can do is we can look at it from all we can do is can kind of compare it slightly with international studies looking at comfort with health and social care professionals from other LGBT folks, and it's markedly more positive across the board, to be quite honest with you, which I think is really positive. So okay, great. I shall move on. Oh, sorry, there was one there I missed. Internalized homophobia is something else that came out. So there was a small cohort of individuals who were incredibly angry that I would even think that being part of the LGBT community or being gay in any way had any impact upon their experience as being a family carer. It really, really upset that I would use that language, that I would even think that, which I found really, really interesting. And I obviously I'm assuming internalized homophobia, which is perhaps not absolutely not correct in most cases, perhaps, but there's definitely an undercurrent of it there. And I was very interested by that, to see that, particularly because, you know, one person said, well, you know, would you ask my sister, who's also a carer, who's straight, if her sexuality is impacted by being a family carer? And I was like, well, actually, yes, I would. I wrote a paper on it because, you know, it absolutely is. But people very often assume when we talk about sexuality, you're only talking about your attraction to other people, when actually all of us, our sexuality is imbued in everything we do. If you do your hair during the day, you know, very often that's you know, how you express yourself that way. So it encompasses so much more than just simple attraction. So I just found that quite interesting. So
Sorry,
let's
Zoe, there's another question there from
oh
Sharon.
how were the participants selected? So they self-selected. So I put it out there to, I sent out the link to as many organizations, as many community groups, both in family caring and in the LGBT community as possible. It was published by GCN, which is Gay Community News, which is a big kind of community newsletter here in Ireland. I basically got it out to as many people as I could. It went out through as many lists as I could get it out onto. Um, so yeah, I mean, it wasn't. I did check in with our research subgroup, and got permission to post it on, using the same methods that I as a staff member evaluate any request to share research that comes into our organisation. We made sure that I met all those criteria as well, and did publicise it on the family care, on the Carers Week page that we share research requests on. Did disabled people get involved? Yeah, so we have particularly more so folks who had our neurodiversity. We quite a few neurodiverse participants who are caring for other people as well involved. So we asked them, those a few comments about being disabled and being queer and being a carer all came up as part of the data. Yeah. And that's something I would like to do when I do my interviews. I'd like to particularly make sure that I involve disabled people in the interviews as well. A lot of the time, particularly because there's, and actually it's a quote that I don't think I have included in my later section, where it's a case of, like, you know, so many of the queer community are disabled themselves, that we understand the disabled community perhaps better than others, which I think is a really good point. So yeah, absolutely they were. Okay, so yeah, okay, Grant. I think I've covered those questions, so I shall move on. So this, I think, might be the bit that you guys are super interested in, perhaps. Experiences with health and social care professionals. And so, like I said, in general, it was really positive, or it was neutral, which is also good. You know, you're just looking for not negative attitudes towards health and social care professionals. The discomfort that was there, that people did mention, was around health and social care workers in the home, mainly being the result of privacy and caring concerns. So if there was discomfort, people said, yeah, I'm not super comfortable with people being in my house. Again, it was more so around of, like, I don't really like people in my space, or I don't know if I want to leave the person I care for with them without me being in the house. And I think that is something that is common across family caring in general. I think that's something that a lot of family carers and family members would express some concern about. Only natural, you know, but that was pretty much, that was the main driver of any discomfort that was reported. One thing that people did say, again, you know, we have quite a lot of particularly home care workers who are coming from other countries, and there was some responses who were kind of, people made assumptions really about people from those countries being more conservative, and as a queer person having a slightly heightened level of discomfort because of that assumption, which is not a particularly nice assumption perhaps to make, you know, just assuming that because somebody is not from Ireland, that they're from a more conservative country and therefore they're going to hate gay people or whatever it is. And you're like, well, that's not necessarily, that's not the case. You know what I mean? But that was mentioned, I think, twice or three times by different people about some level of discomfort around people who weren't from an Irish background, making an assumption of conservatism from them. But for some, their sexuality was a concern and would be a concern around health and social care professionals. And this was particularly true for those coming from rural areas. And it's the kind of standard of kind of, well, everybody knows each other. I don't want people to know my business. I don't want the home care worker who knows my mom to be coming in and that kind of stuff. So these are two examples of two questions that I asked that looked at this issue. So on the left-hand side there, I asked questions. So on a scale of 1 to 5, where 1 is completely uncomfortable and 5 is completely comfortable, how comfortable are you or would you be with a HSE home care worker providing respite care in your home environment to the person you care for? So you can see there, it's quite high. Like it's if you look at 4 and 5 together, which should be the completely comfortable and comfortable, it's pretty high, and it's relatively low response rates for the uncomfortable and pretty uncomfortable. And then on the right hand side there, I specifically asked a question: have you ever experienced homophobia or transphobia from a health or social care professional? Now, obviously, 22.4% saying yes, they have is not good. I'm not saying that's good. You know what I mean? That's still 22.4% more than you want, and I know that the HSE want, and the health and social care professionals at large want, but in comparison to a lot of other studies, that is incredibly low. The other studies are hovering at sort of 60-70% saying yes, I have. So that's quite a difference on these particular questions. These are some quotes from the qualitative statements that were put in. So people were sort of assuming the question refers to my sexuality. I'm completely comfortable. HSE home care workers provide a service to the patient, and that is their job and priority. It's expected that any assessment or thoughts about family members should be professional at all times. A lot of the carers, like I said, this is a lot of the carers are coming from more conservative countries or cultures, so there's an element of wariness there as a queer woman. And then somebody said, I struggle to fully trust the HSE. And again, I think that one might be somewhat common. Not entirely and warranted or not, but that's a general statement. But that wasn't specific to sexuality, that was just a general statement. So then the next topic is around non-monosexuality. So by that I mean anybody who identifies not as only being attracted to one gender. So this encompasses bisexuality and pansexuality, which are similar terms but used interchangeably, but also are slightly different. Again, I don't want to get into a big debate about the definitions of bisexuality, pansexuality. That's for a different day. Brian, that's a very long comment. I'm going to read it after I finish this, if that's okay. So thank you. The majority of the non-monosexual participants, so people who are bisexual and pansexual, the majority are in heterosexual relationships, and the majority, I think nearly all, were caring for their own children who had disabilities, who were disabled, which is a really interesting different dynamic, because very often the assumption, or a lot of people assume, when you think of a family care, particularly a queer family carer, you assume they're going to be someone who's had to come home and is now caring for a parent. That's the kind of assumption that you would make, but it's not always going to be the case. Like I said, majority of these were caring for additional needs. And these individuals were experiencing feelings of invisibility and erasure from the queer community. So bi erasure is that kind of, whether it's unconscious or not, is this idea of like, well, they don't really exist. You know what I mean? It's like, oh, particularly if you are in an outwardly, heterosexual looking relationship, then forget about it. You're probably not going to be seen as queer by anybody. Your own family, your community. There's big issues with that, both within the LGBT community and in the general population. And that can be really, really damaging for people. There was a reported feeling of needing to keep their sexuality away from health and social care professionals, and that seemed to be slightly stronger than for this group of bisexual and pansexual family carers versus those who are gay or lesbian. And I don't really know why. And that's one of the reasons that this group is who I want to concentrate on in my next phase. So here's some quotes. So about why somebody, for example, wouldn't necessarily be open with around their sexuality to a health and social care professional. There was often an adversarial attitude from HSE nurses, so I wasn't really willing to chance them, giving them any more reasons. So that was any more reasons to be adversarial. I don't want anything to affect the little help I do get from them. If your kids have autism or ADHD, certain services have opinions on your parenting. I don't want them to think I'm any more different than they already do. And that was from a person that was from a neurodiverse parent themselves. So there's a lot going on there in that particular situation. And then my sexual identity is erased by my caring. And I think that goes through for an awful lot of people. You know, parts of their identity, whether or not you're straight or gay or lesbian or whatever it might be, that part of you can be erased by your caring. A lot of your identity becomes erased by your caring over time. You become the carer as opposed to a rounded person with all these different facets. Any did anyone outside support as opposed to being a carer? What do you mean by that, Fiona, if you don't mind me asking? I'm not entirely certain what you mean by that.
I'm just saying, like, did anyone kind of want their son or daughter supported by the state, like outside support, like a PA, for example, as opposed to being a carer themselves?
No, not specifically. I will say most of the respondents seem to be caring for very young children. So like under 16 for sure. They like that was the age. There wasn't necessarily people who were caring for adult children, if you know what I mean. They're adult children with disabilities. So I don't think that necessarily had come into the conversation yet. The idea of a PA service, for example. Yeah, no. They were kind of they were in the parenting mode. This is part of parenting because my kid, you know, is young. Yeah. Okay, Grant. Okay, great. So moving on to strengths and resiliences then. So what I found really, really interesting was that some carers identified skills and experiences developed from being queer that have impacted their caring experience. So I did ask a specific question, you know, do you have any, can you identify any skills or knowledge that that from being an LGBTQ person that has impacted your caring experience or your caring role? I can't think, the question comes up in the next slide. And what people said yes, but what were they? So people identified empathy, resilience, organization skills, and advocacy as core strengths that have come from their life and experiences as a minority group or a member of a minority group in Ireland. And I think a lot of these would be common to other minority groups who have had to face similar kind of exclusions, maybe from society. So here we are. That's the question. Do you feel your experience to date as a sexual minority has provided you with any skills you can use in your role as a family carer? So you can see there, over half said yes immediately. And then another 21% said maybe or sometimes, and only like just less than a third said no, they didn't see any skills or anything like that. And so when I asked for them to kind of expand on that, and what do you mean by that? So I championed my children extremely well as I'd learned to champion myself. Life skills of being in a minority taught me to stand up and fight. And I really like this next quote, as anybody who knows me knows, of course, I'd like this next quote. I understand the system is awful for all of us, and I understand the need to change the system for all of us, which I think is a really, really interesting, considering the amount of change that we've had in LGBTQ policy and legislation over a really short period of time. Like we went from 1993 from decriminalization to 2015 to marriage equality. Like by any measure, that's breakneck speed of policy development for something like this in any country. And so, you know, a lot of people who are still alive, very much alive, and would have been involved in those fights, particularly if you're part of the community and feel strongly aligned to that community before you became a family carer, for example. Learning to adapt to my sexuality over the years and adopting the habit of becoming informed and supportive of other sexual minorities and informative when I needed to equally has helped me adopt a good habit of researching and finding the skills necessary in services, but more importantly, the coping mechanisms to apply a way of thinking and acceptance in how I approach the work of being a carer. And I think that's a really, really strong quote about learning the skills of advocacy through a different means and then applying them as a family carer to advocate for the person that you're caring for appropriately. So I just think that's a really interesting one. And when I reflect on, you know, even just conversations with friends, for example, you're kind of going, yeah, you know, you kind of, you know, when you come out young, for example, you learn to just get on with it. You know, you learn to adapt to these things, and you learn these skills of kind of, you know, making sure people are safe and understanding difference. There was also another really great quote that I took out, which was around like, I understand difference because I was different. So now in my kids, I champion that difference. It makes no, you know, I understand that difference, and I want to be part of celebrating that difference because nobody celebrated mine. But essentially, it was kind of that kind of idea. So moving on then to kind of the more slightly more academic-y bit, and there's a bunch of academic quotes in the next section because I just can't resist a good quote. I'm a demon for a good quote. So looking at intersectionality, anybody who's heard me speak about this for the last number of years know I just bang on about intersectionality nonstop. Poor Liam, our CEO, was blue in the face listening to me talk about intersectionality, but it's so important because if you're looking at oppressions, and I would include family caring and disability, race, sexuality, gender, all within this kind of, if you're looking at intersecting oppressions where things kind of, you know, it's really tough to be a family carer, it's really tough to be a woman, it's really tough to be gay. But if you're a gay family carer who's also disabled, like that's just a lot to be dealing with, you know, and then you add race into that, you know, so you've got a lot of intersecting challenges that can be seen as really, really difficult. But, and traditionally, family care in this area has, family care research in this area has focused on like homophobia and heterosexism experienced by family carers and the barriers to good care and good supports, which is absolutely fair. You know, it's really important to look at the barriers and what's going wrong. But if we constantly only look at what's going wrong and not looking at what strengths people innately bring from their experiences as a minority, as a disabled person, as a person of color, as a queer person, then you're kind of doing people a disservice. You know, you're just assuming that, oh, it must be rubbish to be a family carer and to be gay. You're like, well, it's not actually. You know what I mean? Like, it's not innately bad. So what I want to do is I want to focus instead on the resilience of queer family carers and the strengths that these intersecting identities create, which then positively impact on their experiences. And what can we learn from that as a sector, as researchers, as health and social care professionals? You know, I'm kind of coming from a social work background. Like, what can social workers learn from these intersecting identities that we can then, you know, not assume the worst when a queer family carer comes to us for support. We can't go, oh, well, you obviously had a terrible family life because nobody would like you if you're gay. Like, that's the assumption people would make, you know, and you're like, that's not the case at all. Most people in my research didn't actually have a terrible relationship with their parents. You know, some did, you know, but just as other people have not great relationships for the person they're suddenly required to care for. And like I said, so this in turn will allow a focus on how the unique challenges that do exist for queer family carers can be addressed by supports, HSC professionals who understand these resilience factors. So if you, for example, sitting in a clinic and somebody comes into you and you kind of go, okay, right, so, you know, who's your spouse? And you know, this is my spouse and I'm caring for my whoever it is, to not assume that they've been the victim of homophobia, to not assume that they had a terrible, difficult, you know, dealing with their sexuality and a terrible coming out process, which is what a lot of people to think of, you know, to come at it from a positives, from a strengths-based perspective, which is what a lot of us should be doing in our work anyway. We should be coming at this from a strengths, you know, the strengths that you have when you're a disabled person rather than the deficits, the strengths that you have as a person of color rather than the deficits. So yeah, so that's kind of the way I'm looking at this. So I'm going to move on now and talk about a few little quotes that I just, oh, lovely. And these were quotes that I picked out of readings I've done recently, kind of as a way to kind of lay out this to my supervisors and say, hey, wouldn't it be really cool if I looked at it this way? Because I haven't seen anybody doing it this way. So this was to try and impress my supervisors, which I think it did, which is, you know, that's always nice. So, and intersectionality frameworks aren't always automatically used in family care research, I think. It's not something that's done an awful lot. It's being done more. The application of an intersectionality framework in healthcare research has the potential to create new ways of understanding illness/disability, intersectional stigma, and health inequities, with implications for improving care for individuals and families from different socio-cultural backgrounds. And then the main theoretical implication of the current article, which was from this year, is that traditional concepts in informal caregiving, such as burden and rewards, can be examined from the intersectionality perspective, or at the very least alongside it. This is especially crucial for research focusing on disadvantaged groups such as immigrants, refugees, the LGBT community, and ethno-racial minorities who suffer from multiple social adversities that go beyond the scope of standard situations of caregiving for a family. And I think that's really important to note, because I think a lot of people will kind of go, but like, caring is caring. Like, does it really matter what someone's sexuality is? And you get that a lot from organizations who, for example, say, well, we don't ask any questions about the sexuality of the family carers that we support, because we treat everybody the same. And that's really good in theory. Like, it's really good to have that as a basis, but also that then unfortunately can erase some of the challenges, but then also some of the unique strengths that people from those communities who you kind of quote unquote don't see or don't look for are bringing to the table, and can actually contribute. And I did at the beginning of the year, I did a kind of a test interview for a mock interview, or a pilot interview, that's the word, for going on to my interviews. And I asked the question, like, what can the family care community learn from the queer community, from the person I was interviewing? And they said, well, just understanding how to organize and fight for change is something that the queer community were really good at. We've gotten all of this change in 30 years. Perhaps we can lend our skills to the family care community or the disabled community to do the same. That's not to say that we're better at it. It's just that stronger together. So I just want to say, this is around communities such as the LGBT community have historically been researched from a deficits-based approach that centers problems, risky behaviors, and pathologies. And although this research has made important contributions to the field, it may add to stigma by emphasizing deficiencies among SGM, sexual gender minority individuals, and using cisgender. Cisgender, by the way, is somebody who is not transgender, so it's somebody who whose gender identity aligns with the sex they were assigned at birth. Heterosexual people as the standard to which SGM health is compared. As such, researchers have increasingly advocated for the use of strengths-based approaches which focus on the resources that the SGM communities utilize to persist and thrive despite stigma and adversity. So I think that quote kind of encapsulates it a little bit. Thank you for
you got a question there.
Yeah, thank you. Yeah. Does any of your research focus on the experiences of the family carers of the LGBT? Sorry. Does any of your research focus on the experience of the family carers of the LGBTQ plus community with care needs?
Does that make sense? So
no, I feel like that's what the project does. Maybe I'm misunderstanding your question. Could you say that again?
Yeah, hi, it's Kathy here from the DFI.
Hey, Kathy.
So I think I misinterpreted when I was anticipating the research. I was reflecting on it from the experience of some of our members who have a profile of supporting, so family carers, irrespective of the sexuality, supporting profile. In particular, it's presenting with children, young people who have, who are part of the LGBTQ plus community. So I was kind of anticipating wrongly, I think, the evidence of their experience as family carers to supporting an individual who's, part of the community, but also has either a disabling condition, a disability, or a care need. Does that kind of make sense? Yeah.
Totally. Yeah, absolutely. Yeah. No, that's absolutely fair. So apologies if for the clarity issue. So yeah, so my focus in this research is the family carer as opposed to the care recipient. So I'm centering the family carer who is LGBT, regardless of who they care for. So I did ask a question, and the bulk of people, the bulk of respondents who were LGBTQ themselves in some way were not caring for someone who was LGBTQ themselves. So only a handful were, and most of those were spouses or members of family of choice, so a friend or a neighbor or somebody part of the community. But most were caring for someone who was heterosexual, or that they assumed was heterosexual. I mean, most people will assume their parents are heterosexual unless they know otherwise. That might not be the case. Your parents could be bi, and you just don't know. So that's the assumption. But yeah, so that's the difference. So I hope that's clear.
Yes, perhaps I'm prompting a thought in your head for your next PhD, though, because
my next one, okay.
Yeah, because it does present as a profile, particularly of the emerging profile, given the high prevalence of autism, for example, in the children's disability services, as a support gap for those family carers who are struggling with, you know, the new diagnosis of their children and young people, but then equally the important regard for the identity that the young person has. So it's a really untapped area of research that yeah, it would be great to get some light on.
It is, and I think that comes down to the other assumption that a lot of people make, is that, you know, disabled people in particular aren't sexual, full stop, you know. And I think that's an assumption, that's an incorrect assumption that a lot of people make. And it's, I mean, it's difficult for any parent to think about their children, you know what I mean, growing up in that way, regardless of ability, you know, of disability or whatever it might be. But I think there is that sort of that infantilizing situation where a lot of people just assume that disabled people, particularly intellectually disabled people, aren't sexual in any way, which is just erroneous. And so, but there is some work being done around that.
There is. There's there's a HSC working group. I was kind of excited on your behalf. I thought this is going to be something we can bring to the sexuality working group under the HSC, and it may still well be. But there's plenty of research to be done yet. Pressure.
Look at from my I honestly, if I get one PhD done, that'll be me now. That'll be my lot. Thanks very much. So I'm realizing the time, so I'm not going to go over all of this, but what I wanted to do was kind of the next steps for my research. Like I said, I focus on strengths that people who currently face systemic marginalization have as a direct factor of their identities, rather than because of how they compare to a privileged reference group. Sorry, that was a confusing slide. I'm just going to move on. So learning for professionals. Most of this is kind of have been discussed already. So like I said, Irish LGBT family carers seem to have less negative experiences and views of HSC professionals in other jurisdictions, which is really positive. Is that because of the policy development and change in Ireland and fast legislative development? I believe so, but I can't prove that. And that was something I was like, oh, I could look at that. And you just, you know, for a PhD, you just have to be so single-minded and really drill down. Like I said, queer family carers have disabled skills and traits. Traits is the wrong word, but you know, I hope you understand what I mean, that positively impact their caring, resilience, and skill set. And then it's really important to remember that heterosexual looking relationships don't equal heterosexual individuals, especially in the heteronormative world of family care. So by that, I mean, there's a lot of assumptions that are made in family care, is that if you're a man and a woman in a relationship looking at, you know, caring for a child with a disability, then you're both straight and everybody's straight. And that absolutely could not be further from the truth. You know, so it's just important to remember that. So the next steps, I'm going from breadth to depth. So the breadth, which was the survey, and then the depth, which is now hopefully going to be with interviews with non-monosexual family carers, looking at, with no restrictions on who the cared for person is. So I'm not going to restrict it to parents or anything like that, but I do want to specifically look at non-monosexual family carers because of that idea of by erasure, and just hasn't been looked at in any way in other studies at all. I'm hoping to take a narrative approach, so asking people to tell me their story of their coming out story, or their sexuality story, and then their family care story, to see how those skills develop over time and how they're crossing over, if they are, and how that works in practice. And then really just looking to challenge negative assumptions in research of LGBTQ plus lives and family care lives. So just trying to combat that kind of always, oh, it's always terrible to be a carer, it's always terrible to be a gay person. Is, you know, to try and combat that and say, yeah, it's challenging, it's difficult, but it's not always a bad thing. I just wanted to very quickly put up some thanks to my supervisors in UCC, Professor Maureen and Dr. Fiacre O'Sullivan, and then Care Alliance Ireland, and then obviously the respondents to the study. So like I said, again, I'm coming at this with this is my PhD hat, so that's my website for my project. If you're interested, you can scan that, or you can just go to queercaring.com. And obviously that's my personal email address that's for use for this research. So if you're looking to talk to me for Care Alliance stuff, don't email me on that, because I won't answer. I'll just forward it to my Care Alliance and then come back to you on that. So that's that. So I'm just going to stop sharing.
Zoe. Yeah, we'll give another few minutes if people have any questions, observations. It's fascinating to listen to. Yeah, really well presented. So thank you.
Thank you very much. Great, learned lots. That's always good. At least there's a lot of information to get into. Yeah, absolutely. So Brian, I can see you have your hand raised. There's one question in the chat that I can answer really quickly. So copy of the slides will be up on our website, and also the recording of this will be on our website as well in about a week, probably. Let me just have a chance to edit it down. So Brian, did you want to give your hand raised there?
Yeah, thanks. So it was really interesting, and best of luck with the rest of your research. I just had, I know it's still early days, but I'm just thinking, so we're here in the Department of Health attending this, and so what is it that we should be, what would you want us to be the key takeaway message that to impact policy? Like, what is it that are the specific challenges, or how do we incorporate the strength-based approach into policy making, or into how we provide services, etc.?
So, yeah, it is early days. So now might completely change by the time I publish my PhD. I suppose the big thing is that understanding that that difference is not a bad thing, but also that different types of family carers exist, and the same solutions for one family carer and one type of family carer won't always work for others. So, for example, I think there was there's basically like if you for example, a really good example is the traveling community, for example, and we had the CEO of Exchange House do a presentation not so long ago with us, and Fiona, you were there as well, before Christmas, which is a really good seminar to look back on if you're interested. And like if you are, for example, if you're a family carer from the traveling community, then yes, you're going to be coming up with the same challenges, perhaps accessing respite, accessing services, all that stuff that's in for the general population. But then you're also going to have the added issue of, how do you make a mobile home or a caravan on a halting site accessible for someone in a wheelchair that you're now caring for? How do you navigate those issues? And so there are other things that you need to be aware of, and asking those types of questions and it always comes back to, well, what do you need as an individual, I suppose, in those types of conversations. For example, I know like the Interrai, for example, is I've been on a long journey of where it's at now. And I think making sure that those types of questions about what's your specific circumstances, what kind of, what supports do you need? And some people will say, I don't need anything special. I don't want anything different. Actually, I'm actually fine. But even just knowing, for example, that you could actually, one thing that came up in some of the responses was like, I'd really love to be able to be prioritized for the last weekend in June so that I can go to Pride. So that I would like to be prioritized, at that point, because it happens one time a year and it's when I can connect with my community. And I'd really like to be prioritized at that. I can do any other weekend of the year. Perfect. You don't have to put me in. Do you know what I mean? But like help me prioritize that for me and my connection to my community. And that would go, for example, for someone from an ethnic minority who has a celebration day, for example, you'd hope that those things would be worked with in, respite or day services or whatever it might be to kind of work with the person. So that's probably less policy and more practical supports. I think it's just a general acknowledgement that minority groups exist, and that they're going to have different experiences than the majority, is I think probably the key takeaway. That answer your question?
No, yeah, it was perfect. I'm looking forward to hearing more. Thank you.
Well, okay, great.
Any other comments or queries before we wrap up? Trying to put up your contact details there, Zoe, again before maybe we wrap up.
Sure.
And I think other than that, we'll probably and I know there's some work being done by Eurocares. I see Julia there. Hello. So this isn't being done in isolation, which is always good. As part of our kind of overall work, seeking to influence things at an international level. We're delighted to be collaborating and partnering with Eurocares.
Yes, Eurocares published. It was just not too long ago, actually, Julia, wasn't it? The discussion paper.
Yeah, we published a position paper on LGBT carers in Europe at the beginning of the year. We didn't do any primary data collection for this. It was mostly taking stock of what is going on. And as you pointed out, Zoe, at the beginning of your presentation, there is not much research that has been done at the moment in Europe, apart from the UK. So I mean, I really look forward to reading what will come out of your research. I think this is really exciting and important work. So thank you so much for your contribution to the paper and to the state of the art of research in general.
Thank you. Yeah, I always love when people say, I'm looking forward to reading it. I'm like, I'm looking forward to reading it. Because if I'm reading it, then it means I wrote it. And that's always a nice part.
I think on that note, we will finish up. Thanks, everyone. Thanks again, Zoe. And we look forward to continuing to connect with you over the coming years.
Yeah. Great. Thanks, guys. Thanks,
Thanks,
everybody.
everyone. Bye-bye.
Thank
Bye
you.
now.
Bye.
Thanks, everyone. Bye.
Bye.